Hi guys, welcome to this session where I will be dealing with drugs used for the treatment of gastric ulcer or peptic ulcer disease. See, before going further regarding the drugs which we have in treatment of gastric ulcer, we need to have a small knowledge on what exactly is gastric acid secretion. Of course, there are lots of physiologies which is involved here, but what I am going to explain is only those physiology which is required for understanding the mechanism of action of anti-ulcer drugs, right? First, let's start with the physiology of gastric acid secretion. Consider, here is where your parietal cell is. This is where your parietal cell, we know from the parietal cell is where the gastric acid is getting secreted. Nearby we have the mucous cell. Here is where the mucous cell is. We also know that from the mucous cell, mucus and bicarbonate tend to be released, which will behave as a natural anti-ulcer mechanisms. Now, what are the different things which is responsible for the gastric acid which is secreted? What is the gastric acid which is secreted? Is it sulfuric acid? No, it's going to be hydrochloric acid. The gastric acid in our body is hydrochloric acid. How this is going to be secreted? This is going to be done with the help of a particular pump or a transporter, which is responsible for pushing out of two different positive charges from one area to one another area. Usually what happens whenever a positive charge is been let out, in exchange a positive charge must be taken in to maintain the membrane stability. Or if a positive charge is let out, one more negative charge should be let out. But here two positive charges are being let out, which means it is going to be against the gradient. We know that whenever we have a particular transporter which is actually involving against the gradient, it is going to be an active transport, and if it is an active transport, we need energy for that function to perform, and that's why this pump which we are going to talk about is also called as H plus K plus ATPase pump. So here's where the pump is. With the help of this pump, we have H plus which is let out and K plus which is let out. As two positive charges are being let out, we need energy molecule for this process to occur. That's why this pump is also called as H plus K plus ATPase pump. H plus K plus ATPase pump. As these are involving only regarding protons, right, positive charged molecules, these are also called as proton pumps, simple. Now, what are the different stimuluses and the inhibitory responses which the body has for this proton pump? If proton pump is stimulated, acid secretion will be increased. If proton pump is inhibited, acid secretion will not occur. What are the different stimuluses for this proton pump? Three major stimuluses are there for increasing the gastric acid secretion. The first one is called as histamine, which binds with the receptor on the surface of the parietal cell called as H2 receptors. The second stimulus is gastrin, which binds with gastrin receptors. And the third stimulus is acetylcholine, which binds with acetylcholine, that is M3 receptor, which is there on the parietal cell. So we have three major receptors on the surface of parietal cell which might stimulate the gastric acid secretion: H2, gastrin and M3 receptor, which is stimulated by histamine, gastrin and acetylcholine respectively. Now, how this receptor stimulation tend to occur? H2 receptor is actually a GS coupled receptor, whereas both of these, both M3 and G receptors, both are GQ coupled receptor. From general pharmacology, we also know that GS coupled receptor, how it is going to be producing its action, guys, by increasing the levels of cyclic AMP. This GS receptor tend to stimulate or increase the level of cyclic AMP. Intracellular cyclic AMP levels will be increased. On the other hand, GQ receptors will increase IP3 DAG. GQ receptors will increase IP3 and DAG. What will happen further? Is it going to be a stimulatory or inhibitory, guys? We have already explained it. It's going to be a stimulatory one. Both tend to stimulate the proton pump, thereby increases the gastric acid secretion. The second one, the histamine which is being released, which is binding with the H2 receptors and producing the effects, is actually going to be coming from a cell called as enterochromaffin-like cell, ECL cells. So it's going to be the histamine which is going to be released from the cell, and that cell is called as enterochromaffin-like cells. Here we're going to draw the diagram of the enterochromaffin-like cell. And so this is your ECL cells. from the ECL cells is where your histamine which is going to be released, and this histamine in turn will bind with H2 receptor, stimulate the histaminergic receptor, thereby increasing the gastric acid secretion. M3 is going to be stimulated by, we know that, right, acetylcholine. Acetylcholine is secreted out from the vagus nerve which is supplying the gastrointestinal tract. So from the vagus nerve, acetylcholine will be secreted, and that will bind with the M3 receptor on the surface of the parietal cells. Apart from that, we also have one more receptor on the surface of enterochromaffin-like cell for acetylcholine, and that receptor is M1 receptor. Also, we have one more receptor on the surface of enterochromaffin-like cell for gastrins. This is gastrin G receptors, which means gastrin which is released will bind with both the G receptor which is there on the enterochromaffin-like cells and also on the parietal cells. Both tend to be stimulated by gastrin. So if the gastrin receptor is stimulated on the parietal cell, GQ receptors will get stimulated, IP3DAG thereby increases gastric acid. If those gastrin receptors which is there on the enterochromaffin-like cells, if those are getting stimulated, more histamine tend to be released, and that histamine in turn is going to be increasing the gastric acid secretion. Now what about the acetylcholine which is released? The acetylcholine which tend to be released again tend to be binding with M1 receptor and stimulated. Not only that, M3 receptor also will be stimulated with that. Now comes the next important query. Which is the most important stimulus for gastric acid secretion for acetylcholine as per acetylcholine is concerned? Is it M3 receptor or is it M1 receptor? Which is the primary stimulus? The primary stimulus is going to be M3 receptor, guys, right? M3 receptor tend to produce more gastric acid secretion than M1 receptor which is there on the enterochromaffin-like cells. But unfortunately, for decreasing the gastric acid secretion, we don't give M3 receptor blocker. Why? Because M3 receptor is not only there in parietal cell, it is there in many different areas in the body. So these M3 receptors, if it is getting blocked throughout the areas in the body, the patients might land up in lots of anticholinergic adverse drug reactions. So as per pharmacology is concerned, we don't target the M3 receptors, instead we target the M1 receptor, with which of course I can decrease the gastric acid secretion to a little bit, but at the same time I can prevent the anticholinergic adverse effects from occurring in the patients. Is that clear? Now let's move further. What are the other inhibitory responses for this gastric acid secretion? Again, we have somatostatin. The somatostatin tend to be a GI coupled receptor. If it is a GI coupled receptor, it tend to be decreasing the intracellular cyclic AMP concentration, which further tend to be inhibiting the release of gastric acid. Clear? Apart from that, we have one major mechanism that is not done by the parietal cell, guys. That has been done from the mucous cells. And what is that? The synthesis of mucus and bicarbonate. What is going to be the primary stimulus of the mucus and bicarbonate secretion? Prostaglandin E2 and prostaglandin I2. We have PGE2, prostaglandin E2 and prostaglandin I2. Both tend to stimulate the mucous cells. Thereby, from the mucous cells, what is going to be released? Mucus and bicarbonate. Both these things is going to be released. And this in turn, bicarbonate tend to have direct inhibitory action on the hydrochloric acid. It binds with hydrochloric acid and produces inhibition of it. More interaction between hydrochloric acid and the bicarbonate tend to produce bloating, right? Because we know because of the release of carbon dioxide, the patients will be having bloating or belching phenomena. What about the mucus which is secreted from the mucous cells? This mucus will form a layer. It forms a protective layer on the gastrointestinal tract, thereby prevents the gastric acid from damaging the cells which is there on the gastrointestinal tract. Now, what are the stimuluses for the release of prostaglandin E2 and I2? From where it is getting synthesized, guys? Arachidonic acid. Remember, we explained that previously. Prostaglandin E2 and I2 will be synthesized from arachidonic acid with the help of an enzyme called as cyclooxygenase enzymes. Now, we have some drugs which might inhibit the cyclooxygenase enzyme. If cyclooxygenase enzyme is inhibited, what will happen? Prostaglandin E2 and I2 will not be synthesized. Mucus and bicarbonate production will be compromised. Because of it, the patient will land up in gastric ulcer symptoms. So what is the drugs which we have? NSAID, non-steroidal anti-inflammatory agents. NSAIDs tend to inhibit the cyclooxygenase enzyme. Not only NSAID tend to be producing competitive reversible blockade. We have a non-competitive irreversible cyclooxygenase inhibitor, and that is aspirin. So aspirin and other NSAIDs tend to inhibit this cyclooxygenase enzyme. That's the reason why we have a condition called as NSAID induced gastric ulcers. Out of all the NSAIDs, the least ulcerogenic drug is ibuprofen. Ibuprofen is the least ulcerogenic agent. The most commonly used NSAID, ibuprofen, is tend to be having least ulcerogenic property. So what will be the specific drug for the treatment of, or to say specific drug which can be used as an alternative to NSAID to prevent gastric ulcer secretion? That is to prevent the gastric ulcer formation, we have cyclooxygenase type 2 inhibitor. So specific cyclooxygenase type 2 inhibitors tend to have decreased ulcer production. Specific cyclooxygenase type 2 inhibitors tend to have less ulcer production, but of course there is a chance is there, but in comparison to the non-selective cyclooxygenase inhibitor, cyclooxygenase type 2 inhibitors tend to produce least chances of this ulcer production. Now let's move on to the next one. Now let's talk something regarding this gastrin. What are the stimuluses for the release of gastrin? How gastrin is going to be released out? As per gastrin is concerned, first of all, in terms of gastric distension, whenever there is gastric distension, the gastrin will be released, point number 1. In terms of intake of amino acids, there will be release of gastrin. We have acetylcholine and histamine. All these tend to be increasing the gastrin release, which means gastrin in turn tend to be producing, in turn going to be stimulating the proton pump, thereby increases the gastric acid secretion. Now what are the different drugs which we have which might induce development of GERD? Drug induced GERD. I'm talking about GERD, guys. What is GERD? Gastroesophageal reflux disease, GERD. This is because of those drugs which will increase the gastric acid motility from the stomach towards the esophagus, so thereby the esophageal mucosa will get damaged, and that is what GERD is. What are the different drugs which might be inducing GERD? Those drugs which tend to produce smooth muscle relaxation. If those are producing smooth muscle relaxation, the lower esophageal sphincter will not be closing out properly, which leads on to increased reflux of the gastric acid towards the esophagus, causing damage to the esophagus. The first important drug which we have is nitrates, theophylline. The tea which you drink tend to be producing more chances of GERD. Calcium channel blockers, bisphosphonates, especially peroral bisphosphonates, and anti-muscarinic agents. Anti-muscarinic drugs. All these drugs tend to be inducing GERD symptoms, guys. Please note that I'm not talking about gastric ulcer, I'm talking about GERD symptoms. Let's move on further. Let's talk about the drugs which we have currently in treatment of gastric ulcer. So with this basic knowledge regarding how gastric acid is getting secreted, what are the different targets do we have, guys? The most important target, the first one is I can block the H2 receptors. That right? By blocking H2 receptors, I can prevent the gastric acid from prevent the proton pump from getting stimulated. By blocking the gastrin receptor, I can prevent the stimulation of proton pumps. By blocking the muscarinic receptors, I can prevent the proton pump from getting activated. Or all these things, how it is going to be stimulating the gastric acid secretion via the proton pump. So we give proton pump inhibitors. Next, we have certain somatostatin analogs. Then we have certain mucus drugs which might be increasing the mucus secretion, drugs which might be increasing the prostaglandin levels. That is prostaglandin analog agents, and drugs which might be serving as an antacid drugs. Antacid drugs tend to be, we are inducing the pH alteration. We are producing the alteration of pH inside the gastrointestinal tract lumen. Thereby, we can prevent the ulcer from getting developed. So, what exactly is gastric ulcer, guys? There is going to be a mismatch. See, there are certain aggravating factors and there are certain inhibitory factors of the gastric acid secretion, like acid, pepsin, any spicy foods. This might be increase in the gastric acid secretion. So the acid secretion and the mucus layer which is formed inside the stomach is going to be there in a particular balance, right? There is not going to be an increase or a decrease in that. Whenever there is increase in the gastric acid secretion, the mucus secretion also will be increased parallelly. But when there is a mismatch, which means whenever there is decreased mucus secretion or when there is extraordinary release of gastric acid, what will happen is there will be a damage in the mucosa. Because of this mucosal damage, what happens, the acid which is being secreted will be constantly irritating the cells which is there beneath that, leading on to burning sensation on the epigastrium. That's the reason why the patient will be having epigastric tenderness. That's the reason why the patients will be having burning sensation in their abdominal area. All this is because of interaction of the acid on the cells which is there beneath that. Normally, if you have an ulcer, if you have any wound which is there on your skin, the primary treatment process is we will leave it as such, right? We don't want to be constantly nagging that way because we need that cell to be constantly proliferating and close it out. It needs time for that to happen. Similarly, for the mucus, it needs time for that mucus to be reformed and to be resynthesized and to be reclosed. Until then, we don't want the acid to be constantly nagging at it, constantly irritating that. That's the reason why we decrease the gastric acid secretion for a certain period of time, so that the mucus will be reformed, and after that, even if the patient takes any spicy food, it's not going to be irritating the gastrointestinal tract. Let's talk about the first drug which we have currently in treatment for gastric ulcer secretion, H2 receptor blockers. We used to call them as H2RA, H2 receptor antagonistic agents. These H2 receptor antagonistic agents are antihistaminic drugs, guys. First question, of course, everyone will be having that question in mind, whether it is going to be selective only for H2 or is it going to be non-selective, that is binding with H1 also, because if it is binding with H1, there is more chances of sedation to occur. But here, please note that all the H2 receptor antagonistic agents are highly selective agents. These are highly selective agents. What are the drugs which we have, guys? We have the tidin agents, cimetidine. We have cimetidine, ranitidine, famotidine, nizatidine. We all know that in the recent national list of essential medicines, ranitidine was taken out from that list because it is not been seen as essential drugs in the recent edition of NELM. Now, out of all these drugs, the drug which can be given via per oral route, and also it has got approximately 100% per oral bioavailability, is nizatidine. Of course, we have ranitidine, cimetidine, famotidine. All these drugs can be given via per oral or even given via parenteral route. But nizatidine tend to have the maximum per oral bioavailability. Approximately 100% per oral bioavailability is seen with nizatidine. What's the mechanism of action, buddies? What's the mechanism of action of these drugs? As we told, these drugs are competitive blockers of H2 receptors. Competitive H2 receptor antagonistic agent. Second important point, is it going to be decreasing the nocturnal acid secretion or meal stimulated acid secretion? It decreases both nocturnal and meal stimulated. Nocturnal means your basal. Meal stimulated acid secretion. Both tend to be inhibited. That's the reason why this drug is preferred to be given during evening times. Preferred to be given as a single evening dose than given at morning doses, because we can utilize the drug up to the maximum. The efficacy is going to be maximum whenever this drug is given as a single evening drug dose. The next important one, what are the different things which is going to be producing? It causes what all things? The gastric acid secretion is going to be decreased because histamines tend to be blocked. H2 receptors are getting blocked. There is more amount of histamine. The substrate molecule which is going to be binding with the receptor, that is histamine, it's going to be accumulated in more. Because the receptor is getting blocked, rebound increase in histamine secretion might occur. Those histamine, even if it is getting secreted, it is not going to be binding with the receptors, but those histamine has got more propensity to bind with H1 receptor which is there in the bronchus. Thereby it might produce bronchoconstriction. So the bronchoconstriction due to H2 receptor antagonistic agent is due to its interaction with the H1 receptors on the bronchus. So there is going to be bronchoconstriction, and the pepsin secretion also is going to be decreased with these drugs. Pepsin secretion also is going to be decreased. For what all different conditions can we use these histamine antihistaminic agents? Currently, the proton pump inhibitors has replaced majority of the uses of H2 receptor antagonistic agent, but till we use this drug, we prefer giving this drug especially for preoperative aspiration induced pneumonia. We use it preoperatively to prevent aspiration induced pneumonia during surgery. Prevent aspiration induced pneumonia preoperatively, we prefer giving H2 receptor antagonistic agent. Out of all these agents, the prototype drug which we currently have is your cimetidine, guys. As I've told, currently we don't use this cimetidine. Most commonly, the proton pump inhibitors has replaced this cimetidine or the H2 receptor antagonistic agent. Why? Because it has got lots of negative issues. What are the disadvantages of cimetidine? First important point, it serves as a microsomal enzyme inhibitor agent. Microsomal enzyme inhibitor agent. The second one, cimetidine tend to decrease the hepatic blood flow. It decreases hepatic blood flow. And the third one, the adverse effect of cimetidine, guys, gynecomastia. A most famous drug which produces gynecomastia, cimetidine. There will be loss of libido, and the patients might have decreased sperm count. The sperm count might be decreased when the patient is on cimetidine, because it tends to displace the dihydrotestosterone from its binding site, from the cytoplasmic receptor. Dihydrotestosterone, once it is interacting with its receptor, it is going to be useful, but when it is been displaced from that, it is not going to be useful, because we know the active form of testosterone is going to be dihydrotestosterone. And apart from that, when the patient is continuously on treatment with cimetidine for a long time, there is going to be development of tolerance. Tolerance develops. This tolerance is due to downregulation of receptors. This tolerance is due to downregulation of receptors. What exactly is this downregulation, buddies? Consider we have the cell, that is your parietal cell, and we have the histaminergic receptors on the surface. H2 receptors are there on the surface. When these receptors are getting blocked, recurrently on long-term therapy, there is going to be the influx of these receptors inside the cell. This is called as downregulation of the receptors or internalization of the receptors. Because of downregulation, which means only less receptors will be expressed out. When the receptors are not being expressed out, the action of that drug also is not going to be seen in those patients. So that's the reason why the tolerance develops as per cimetidine is concerned. Apart from that, we have the recent newer drug which can be given via per oral route, that is famotidine. Famotidine carries less risk of adverse events. It tend to have less adverse drug reactions, and it is better tolerated via per oral route. Better per oral bioavailability, and these are tolerated at a better level as compared to cimetidine. Guys, now let's talk about the most important, to say this is the drug of choice for the treatment of gastric ulcer, that is proton pump inhibitors, PPIs. Proton pump inhibitors. So these are a group of drugs which is currently, as I've told, for any type of gastric ulcer, be it stress induced or any drug induced, any other things, the drug of choice is going to be proton pump inhibitors. These drugs together we used to call them as prazole drugs. The drug name is going to be ending with prazoles. We have pantoprazole, rabiprazole, tenotoprazole, lansoprazole, many different omeprazole, many different prazoles are there. But all these are pure, the name is going to be ending with prazoles. So what's the basic nature of these drugs? Please note, I'm just going to write on the salient features of these proton pump inhibitors. The first one is majority of those drugs are acid liable agents. Majority of these drugs are acid liable agents, which means when you give it after food, the drug might not be effective. The drug will be broken down in the gastric acid itself. So you have to take it before food, and that's also one of the reason why majority of the drugs like your prazole drugs which are currently used in practice are always gastro-resistant tablets, or it is given in capsule forms. Why? Because we just try to make sure that the drug is going to be surviving the gastric acidic pH which is there inside the stomach. The second point, this tend to produce dose-dependent acid suppression. It tend to be producing dose-dependent acid suppression. As the dose increases, more acid suppression tend to occur. The next one, which is going to be decreased? Is it resting or the meal stimulated? Again, like H2 antagonists, both resting and meal stimulated is going to be inhibited. Meal stimulated acid secretion will be inhibited. Will it be having any reflex increase in the pepsin levels, reflex blockade in the intrinsic factor levels? There will be no effect. There will be no effect on pepsin. Pepsin levels will not be altered. There will be no effect on intrinsic factor or juice volume. The gastric juice volume will not be increased, or the GI motility. Nothing is going to be altered with these drugs. As I've told previously, we have many different prazoles. How these drugs is going to be producing the effects? Consider you take this tablet via per oral route before food. For example, I'm saying we take pantoprazole. The patient is taking pantoprazole before food. The pantoprazole moves via the esophagus, gains entry into the stomach, and it will not be activated there, right? The drug will move into the intestines. Now, from the intestines, the drug will get absorbed. After it gets absorbed, it gains entry into the blood vessels. Consider here is where the blood vessel is. Here is where the blood vessel is. And here is where your cells are. This is your parietal cell. These are your canaliculi. Here is where the proton pump is going to be. Here is all we have the proton pumps. Now this drug molecule, that is your prazole drugs, gains entry into the cell from the blood vessel. Now as this drug will get accumulated in the cells. Now these drugs will get accumulated inside the cells. After it gets accumulated, this drug will be waiting for the proton pumps to open. Once when the proton pumps are opened, it is going to be binding with those pumps and tend to be inhibiting it, right? Simply put, as I've told already, these proton pumps, this proton pump inhibitor drugs like your omeprazole or pantoprazole, these drugs are acid liable agents, and also the bioavailability is decreased with food. Bioavailability is decreased with food. That's why it is always taken on empty stomach. When taken on empty stomach, it gets absorbed, and after absorption, it attains a particular Cmax. Right? What is Cmax? The maximum concentration of drug which attains in the plasma. So the Cmax will be attained after 1 hour, and when the patient, now when you wait for half an hour to 1 hour times, and after that if you take a food, the proton pumps will be actively will start secreting the acids. That is, proton pumps will be opening and it will start functioning, and when it is starting to function, this drug will bind with that proton pump and tend to inhibit it. What type of inhibition is that? It's going to be a non-competitive, irreversible inhibition of the proton pumps, which means immediately after its binding and producing its inhibition, later on the drug will be excreted out from the body. But even after the drug is excreted out from the body, the effect of that drug will be staying over there. The effect of the drug will be there. That's the reason why we used to call them as hit and run drugs. These are also called as hit and run drugs. These are also called as hit and run drugs. Why? Because as I've told, even if the drug, whole of the drug is been excreted out from the body, the drug's effect will be continuously seen within that body. Now, out of all these drugs like pantoprazole, omeprazole and rabeprazole, as the name itself implies, rabeprazole is what it tend to have a rapid onset of action. Rabeprazole tend to have the rapid or fastest onset of action. And the next important question, as I've told, these drugs are acid liable agents. So usually what we do is we give entry coated tablets. But for certain drugs, there is no need for this entry coated, because I'm talking about most acid stable proton pump inhibitors. We're going to talk about most acid stable proton pump inhibitors. The most acid stable is tenatoprazole. Tenatoprazole is the most acid stable, greater than pantoprazole, which is greater than omeprazole, greater than lansoprazole greater than rabeprazole. Rabeprazole is the least acid stable agent. It will be broken down at a faster rate. So rabeprazole must be administered as gastro-resistant tablets or entry-coated tablets. But tenetoprazole, there is no need for that. Even if you have administered that, of course, the bioavailability is not going to be very much lesser for those drugs. Out of all these drugs, the drug which has got the maximum pKa, that is the drug which tend to have a more pKa value, is rabeprazole. Highest pKa. What is pKa, buddy? The pH in which 50% of the molecule will be ionized, 50% will be unionized. This molecule, this rabeprazole, has got the highest pKa, which is around 5. pKa of the molecule is around 5. Now, omeprazole, one of the most prototype drugs out of all these proton pump inhibitors, tend to have certain actions in the microsomal enzymes. Omeprazole tend to inhibit cytochrome P2C enzyme and tend to induce cytochrome P1A enzymes. As it is inhibiting cytochrome P2C enzyme, it tend to block the activation of clopidogrel. It tend to block the activation of clopidogrel. What is a clopidogrel? Clopidogrel is an antiplatelet drug. It's a P2Y type 1,2, right? But P2Y12 inhibitor. It's a non-competitive, irreversible P2Y12 inhibitor, antiplatelet drug. Clopidogrel, actually, it's a prodrug, guys. It needs to be converted to the active form for its antiplatelet activity to be there in the patient. But when you give omeprazole in those patients, what will happen? Omeprazole will inhibit the cytochrome P2C enzymes. Cytochrome P2C enzyme, especially cytochrome P2C19, is the enzyme which is involved in the activation of clopidogrel. When that enzyme is getting inhibited, clopidogrel will not be converted to the active form. The antiplatelet activity will not be seen in that patient. One important drug interaction of omeprazole and clopidogrel. Second important drug interactions, this omeprazole also tend to increase the levels of diazepam and phenytoin. Increases the blood levels of diazepam and phenytoin because of the same cytochrome P2C inhibition. Because of that, the drug metabolism tend to be affected, leading on to there might be increased toxicity of diazepam and phenytoin in those patients. But which prazole drug can be safely administered with these stages? This is an important question. To say which has got the least microsomal enzyme inhibitory or inductory property, lansoprazole tend to have the least effect. Lansoprazole, even pantoprazole, has got very less effect. But the least effect is seen with lansoprazole. Least effect is seen with lansoprazole. Now let's talk about the adverse drug effects of these drugs. Proton pump inhibitors. Most importantly, I hope you remember that, guys, during the initial times in general pharmacology itself, we were explaining an important concept. That is, many different pHs which is there within the body are mostly of alkaline nature, except for the gastric acid and the urinary tract. Both are going to be in the acidic pH. Why? Because we eat a lot, right? We eat a lot of things and we don't want the intestines to land up in an infection. This acid which is going to be secreted in the stomach serves as a barrier. It prevents the infection. It prevents the bacteria or the microorganisms from the food or any other things to land up in the intestines. The basic function of the acidic pH is like a purifying complex, just like that. But when you decrease the gastric acid, when you block the proton pumps, the acid secretion will not occur. When the acid secretion doesn't occur, there is more chances of the intestines to land up in infections. So there is more chances of increased intestinal and respiratory infections. Increased chances of intestinal and respiratory infections. There might be compensatory hypergastrinemia. There might be compensatory hypergastrinemia. Because acid secretion is decreased, in order to increase the acid secretion, gastrin levels might be increased again. Patients might develop atrophic gastritis. Atrophic gastritis. Some patients rarely might develop gynecomastia and erectile dysfunction on long-term use. But apart from that, we have one major issue, and that is proton pump inhibitors. When it is taken, for seeing its maximum effects, we need at least 5 days of continuous therapy with proton pump inhibitors. But these proton pump inhibitors, as it is decreasing the gastric acid secretion, the absorption of calcium tends to be hindered, because for absorption of calcium, we need the acidic pH. If the acidic pH is compromised, calcium absorption will not occur. So when the calcium levels in the blood tend to fall down, right, because absorption is getting hindered, right, the calcium level in the blood tend to fall down. So what are the compensatory? The alarm signal. Now the alarm gets stimulated, and what are the compensatory responses, guys? The body will try to increase the level of calcium in blood. How will it try to increase the level of calcium in blood? It tries to increase the calcium absorption, but it couldn't do that because the acidic pH is not there. It tries to increase the reabsorption of calcium, but already the calcium level is very much low. So we have to increase the calcium levels at an emergency procedure. At that time, the body will try to take out the calcium from the bone. It induces osteoporosis. Because of this, osteoclastic activity will be induced. Because of it, the calcium will be moving up to the blood, so that the blood calcium level will rise back. But at the same time, we are losing the bones. So there is more chances of osteoporosis, especially when this drug is taken for a longer duration of time with lesser calcium supplementation or lesser calcium levels in the blood. It might produce hip fractures, especially in terms of female. So there is more chances of osteoporosis, which might land up in hip bone fractures. Hip bone fractures, especially in female. Is that clear, guys? These are the important features regarding the proton pump inhibitors. Now we'll move on to the next one, antacids. Antacids. What does the antacid do? Antacids tend to increase the pH, guys. Simple concept. We are giving the bicarbonate, we are giving the mucus, and this bicarbonate and mucus tend to be interacting with the gastric acid, thereby suppress it. It tend to increase the pH. Increases the pH to more than 4 inside the stomach. So because of this, what are the different effects which can be seen in those patients? There is going to be increased pepsin activity. The pepsin activity is going to be increased. There might be reflux hypergastrinemia. Reflux gastrin might be released. Because of this both, especially because of hypergastrinemia, there might be acid rebound. Increased secretion of gastric acid, and there might be increased GI motility. These are the two major effects which can be seen with antacids, guys. Antacids, antacid gel, which we use most commonly. Out of all the antacid gels which we currently have, the most efficacious drug, maximum efficacy is seen with magnesium hydroxide. Magnesium hydroxide. What is this efficacy, guys? Efficacy means the drug which has got maximum acid neutralizing capacity. The drug which tend to have maximum acid neutralizing capacity is your magnesium hydroxide. And apart from that, the increase in acid rebound is there, right? This acid rebound is going to be maximum seen with calcium, carbonate. Apart from that, we have certain other antacid agents. The most potent or the maximum potency is seen with which drug? That's what calcium carbonate is. So calcium carbonate tend to have most potency and also tend to produce most acid rebound phenomena. Out of all the agents which we currently have, we have two major ions which is responsible for the antacid effects. One is your aluminum, the other one is magnesium. Please note that aluminum tend to behave as a smooth muscle relaxant agent, and also it behaves as a mucosal astringent agent. On the other hand, magnesium is a laxative, acts as a laxative, and also it tend to induce or stimulate cholecystokinin release. So what's the take home point at this point? Why did we have a need to know these natures of individual ions? Aluminum as it is a smooth muscle relaxant agent, is associated with constipation. Aluminum is associated with development of constipation. On the other hand, magnesium is associated with development of diarrhea. This is also one of the reasons why, in terms of antacid gels which we currently have in the market, contains both aluminum hydroxide and magnesium hydroxide together. Why? Because this aluminum and magnesium, both when given together, the gastrointestinal side effects can be compromised. The side effects will not be there in those patients. That is the primary reason why we give both of these drugs together. Also, the efficacy tend to be increased, but the reason, if you want to state one reason for the combination, it's going to be the prevention of the adverse effects due to this combination. Is that clear? Please remember with this mnemonic, guys, aluminum causes minimum stools. Aluminium causes minimum stools, magnesium causes easy stools. So aluminium causes constipation, magnesium causes diarrhea, right? Now we'll move to the next one, that is sucralfate. What's the function of sucralfate? As the name itself there, it is an aluminum salt of sucrose. It's an aluminum salt of sucrose. Normally, consider here is where the intestines, gastrointestinal tract is, and here is where the mucous membrane is. There is a damage on the mucous membrane. There is a damage on the mucous membrane which tends to lead on to gastric ulcer symptoms. Now, when you administer sucralfate in this patient, the sucralfate, as I've told, it's an aluminum salt of sucrose. This drug, in terms of whenever it is there in acidic medium, the aluminum will be removed out. Aluminum gets released out. Because of the release of aluminum, aluminum is a positive charged molecule. When from the surface a positive charge has been removed out, this molecule will be converted to a negative charged molecule. This negative charged molecule will interact with positive free radicals, positive radicals or positive molecules which are released due to mucosal damage. Because of damage to the mucosa, it will interact with the positive charged molecules. When this negative charged molecules is interacting with the positive charged molecules that is released because of this mucosal damage, and in those conditions this drug, sucralfate will form a paste-like substance. It will form a paste-like substance. So normally sucralfate, when it is administered, it will not produce any paste-like substance, but only when there is hyper acid secretion, whenever there is more amount of acid secretion, and also whenever there is mucosal damage, it is going to be interacting and producing a paste-like substance, and this paste-like substance in turn will get deposited in those areas. This paste-like substance will get deposited in those areas, thereby prevents the gastric ulcer from progressing further. Right? It just promotes healing. It's not going to be producing any healing complexes, but it just prevents the damage from worsening. But unfortunately, as it is an aluminum salt of sucrose, there is more chances of the patient to land up in what? Is it constipation or diarrhea? The patient might land up in constipation. Why? Because aluminum causes minimum stools. So most important adverse effect of these drugs is it might produce constipation. Not only that, some patients might develop hypophosphatemia. This is also one of the reasons why sucralfate is actually contraindicated in patients with hemodialysis. Sucralfate is contraindicated in patients with hemodialysis. Why? Because the aluminum might be overloaded in their blood. There might be overload of aluminum. That's the reason why this drug is contraindicated in patients who are on hemodialysis. These are the salient features of sucralfate, guys. Now, all these drugs tend to be useful in the treatment of gastric ulcer, but apart from that, we forgot to talk about one important area, the cause of this gastric ulcer. It might be stress induced, or it might be a mucosal damage because of any drug induced. We have seen all the different reasons. One important reason is we have a bacteria named as H. pylori, Helicobacter pylori. What's the treatment of choice whenever a patient has been found out that the patient is having H. pylori infections? So the treatment can be classified into two major types, guys. Where you are seeing the patient with H. pylori infection. Is he getting infected with H. pylori in those areas where there is low clarithromycin resistance? When there is low clarithromycin resistance, or when there is high chances of high clarithromycin resistance. Because the drug of choice, we want to choose only one drug, I will choose clarithromycin, because based on that the regimen is going to be different. If a patient has been infected with H. pylori in an area where there is low clarithromycin resistance, we use cap regimen. On the other hand, if there is high clarithromycin regimen, we use bottom regimen. What is cap regimen and bottom regimen? C stands for clarithromycin, A stands for amoxicillin, and P stands for proton pump inhibitor, and we use lansoprazole in this condition. What about the bottom regimen? B stands for bismuth subsalicylate, O stands for omeprazole, or simply put the proton pump inhibitor, T stands for tetracycline, M stands for metronidazole. if a patient has already has got a macrolide resistance, if a patient has been exposed to macrolide in the recent past, he might not be responding well in those conditions. If a patient has been exposed to macrolide in the recent past, he might not be responding well, or if you add clarithromycin again, the patient might land up in adverse drug reactions, because clarithromycin is actually a macrolide. In those conditions, what we do is this clarithromycin is replaced with tinidazole or metronidazole. So we have what's the regimen which we use for H. pylori infections in those patients who have been recently exposed to clarithromycin? We use metronidazole or tinidazole with amoxicillin and with the proton pump inhibitor, and that is lansoprazole. All this drug treatment, we use it for 2 weeks. All this treatment process, we use it for 2 weeks, but if it's necessary, we can extend it up to 3 weeks. That's the maximum level which we can administer. Okay, these are the different drugs which we have in treatment of H. pylori infections, guys. Thank you so much.